Welcome, everyone. My name is Michael Cicchini. I am co-director of our colorectal cancer program here. I'm an assistant professor in medicine and medical oncologist. I'm going to be chairing and moderating this session this evening for Smilow shares about colorectal cancer for Colorectal Cancer Awareness Month. We'll start tonight with some introductions for the various faculty that are going to be presenting tonight. And then we'll jump into their presentations from disease experts in the field of colorectal cancer. Please pose any questions for the faculty in the chat box, and I will be going through those questions and posing them to the faculty, both as each talk concludes, and again at the end of the session. So why are we having this talk tonight? So the care of patients living with colorectal cancer has become increasingly complex as we develop new therapies, radiation techniques, surgical techniques, new radiology, scanning modalities, screening guidelines are changing rapidly. And the Yale Cancer is a national comprehensive cancer network designated cancer center, and it offers state-of-the-art multidisciplinary care to all patients with colorectal cancer. And our goal tonight is to provide information and perspectives from multiple Smilow Cancer Hospital team members that provide colorectal cancer treatment so that attendees can appreciate the role of these various screening, treatment modalities, et cetera, for patients living with colorectal cancer. So I'm going to introduce each speaker now, and I'll introduce them again as they speak, just before they speak. But first, Dr. Vikram Reddy, he's an associate professor of surgery. He'll be speaking tonight about the role of the colorectal surgeon in colorectal cancer management. Dr. Kimberly Johung is an associate professor of therapeutic radiology who will talk about the role of the radiation oncologist in colorectal cancer. Dr. Xavier Lohr, he's a professor of medicine from our digestive disease team who will speak about the role of the gastroenterologist in colorectal cancer management. Dr. J. Kumar Thumar, he's an adjunct professor of medicine who practices in Hartford at the St. Francis Hospital, and he'll be speaking about the role of the medical oncologist in the colorectal cancer management. And we also have Dr. Kevin Billingsley. He's our professor of surgery and chief medical officer of Smilow Cancer Hospital, and he'll be speaking about the role of the surgical oncologist in the management of colorectal cancer. And before we move on to our speakers, I wanted to take a faculty speaker. So I wanted to take a moment to introduce a special guest that we have tonight as well. Cindy Barassi, who is president of the Colon Cancer Foundation. She's spent 25 years developing and managing international consulting projects for nonprofit, government, and for-profit organizations. And the Colon Cancer Foundation is a national movement of thousands of volunteers who are dedicated to a world without colorectal cancer. I'll let you say a few words, Cindy.
Thank you very much. I appreciate it. And I want to welcome everyone tonight, and also say happy Colon Cancer Awareness Month. 45 is the new 50 if you haven't already heard. If you don't mind, I'm going to start just a couple of slides. I think, do I have the ability to do that? Yeah, okay. Okay. It's always this little bit of lag time. Here we go. Okay, so as Dr. Cicchini mentioned, I'm the president of the Colon Cancer Foundation, and I also sit on the steering committee for the New York City-wide Colon Cancer Control Coalition. That is a long way of saying C5, and we work as a part of the New York City Department of Health. And I also serve on the Colorectal Cancer Action Team as part of the New York State Cancer Consortium. And then I also serve finally on a number of other task groups, but I love this one, the Family Health History and Early Age Onset Colorectal Cancer Task Group as part of the National Colorectal Cancer Roundtable. So the foundation has actually been around for 19 years, and our mission is three-pronged: prevention, advocacy, and research. And by prevention, we mean working with the community at large, so people who've never been diagnosed with colorectal cancer, as well as patients and clinicians. And we look to do that through education and awareness. And it could be something as simple as taking what's called our rolling colon, which is a large inflatable colon, into communities in and around New York City and even across the country, and teaching people about what a healthy colon looks like, all the way to what stage 4 rectal cancer looks like. And then even if you go to our website, we've spent a lot of time this year beefing up educational resources for patients who've been diagnosed and clinicians who may not be aware of the rapidly rising rates of colon cancer affecting younger and younger Americans. So I encourage you to visit coloncancerfoundation.org. Second prong is advocacy. And we do that through our annual event is the Early Age Onset Colorectal Cancer Summit, focused on, again, rapidly rising rates in the younger population. We bring faculty from all over the world, as well as patients, caregivers, clinicians, researchers, epidemiologists from all over the world to focus on what's going on with this disease, why it's happening. And then we also advocate for quality of life, fertility preserving treatment, no matter where a patient is being seen across the country. So equal opportunity access to care, no matter where you're being served. And then finally, research. And we've done that historically by supporting young investigators to travel to conferences across the world, promoting their translational research and advances that they're making in colorectal cancer. So for 2022, we have some pretty big, hairy, audacious goals, or BHAGs, we like to call them. We're working rapidly and ferociously to try to raise enough money to provide 10,000 screening opportunities for individuals in underserved and underinsured communities around the country. And our goal is to reach the 21 million Americans between the age of 45 and 49 that are now eligible for screening, if they're at average risk, with our message that screening saves lives. 45 is the new 50. If you're 45, now is the time to talk to your doctor about getting screened. And the way we're doing that is through our website, letsgetscreened.org. So I encourage you again, those two websites, coloncancerfoundation.org, but more specifically, letsgetscreened.org has social media resources, educational resources. So I encourage you to take a visit and learn more about the opportunities to get involved, but also just to share, through your social media channel to encourage people to get screened. And finally, just thank you for having me. I really appreciate being a part of this. I look forward to hearing what everyone has to say tonight.
Excellent. Thank you. So now we'll start with our faculty speakers. And first we have Xavier Lohr, again, professor of medicine from digestive disease, one of the gastroenterologists at Smilow. Go ahead, Xavier.
Thank you very much, Mike. I'm glad to be here. Thank you for the invitation. Hopefully, we'll get some all to learn a little bit from everyone else. I do have no conflicts of interest to disclose. So just to set up the stage, colon cancer is still a very common cancer, third leading cancer in both males and females in our country, and also the third most common cause of cancer-related mortality. So it's still a big problem. One of the things that really is interesting is how big of a difference there is in terms of the incidence of this cancer around the world, with more than 5 times difference from some areas, particularly sub-Saharan Africa and Asia, with the lowest rates, and the more industrialized world with the highest rates of in the incidence of colorectal cancer, which really points towards these behavioral, nutritional, lifestyle factors that probably play a very important role. And in fact, we've learned over the last few years that some of them are clearly associated with them. For instance, obesity is clearly associated with it. Smoking is a big one in terms of increasing colorectal cancer incidence. And in some cases, there are some preventive factors, such as physical activity or intake of dairy products. So those have been associated with actually decreased risk of colorectal cancer. Therefore, there are clear factors that we can do something about it, and modifying some of these aspects can have an impact in colorectal cancer incidence. On the other hand, we've known for a long time that family history matters, and just having one first-degree relative with colorectal cancer more than multiplies by 2 the incidence of colorectal cancer. And the more relatives, the more likely it is that we'll develop colorectal cancer too. And then that's even outside of the well-defined syndromes that are due to genetic defects that are inherited. But interestingly enough, even having an advanced polyp, having a first-degree relative with an advanced polyp puts us a high risk also for colorectal cancer. And that's really important to keep in mind. So it's truly an interplay of lifestyle, environmental, dietary factors, and genetic defects that in some cases do have a disproportionate effect because even though they will affect a smaller number of individuals, the cancer risk is really important in those cases. And this is the good news slide, and hopefully we'll have a few more, but this is the nice trend that we've been seeing since the 1980s in the US, with this very steady decrease in the incidence and mortality for males and females of colorectal cancer. That started even before we started doing screening. So something was already happening, but certainly screening, we believe, has had a lot to do with that. As this slide showing here, which is incidence rate in that red line that goes down as the number of colonoscopies in our country has been going up. So really a clear association, and there's good data showing that actually, colorectal cancer screening does decrease incidence and cancer-related mortality. And unfortunately, though, even though, again, we have this very nice decrease in the older than 50 individuals, this is the worrisome trend that we've been seeing since the early 1990s, this steady increase in the incidence among the 20 to 49-year-olds, which we've seen in other cancers too, but in colon cancer it really has been quite significant. And as we look at the at this increase, what stands out here is that this carries through along all individuals that have been born since the 1960s. And that's what's reflected here. These are individuals born from the 1960s to the 1990s. And in all those cases, what we see is this trend going up in the early onset colorectal cancer, which is very different from this trend in the older individuals that were born before 1960s in the US, where we see this a significant decrease in that incidence, to the point that among adults younger than 55, there's been a 51% increase in the incidence of colorectal cancer from 94 to 2014, and an 11% increase in mortality from 2005 to 2015. So that's something that we really need to tackle. And it's interesting to see this in this graph here. This is individuals age 45, and these are the years from 1975 to 2015, and the upper one is age 50. And as you can see here, and that's incidence among this age group. And what we can see here is that individuals that in 2015 were 45 had the same incidence that individuals who were age 50 in 1993. So as Cindy said, and that we want to stop repeating it, 45 is the new 50 in many different ways. And that really tells you why 45 is the new 50, because we are seeing these numbers looking similar to what the incidence was 30 years ago. So because of all that, the American Cancer Society was the first that really started becoming very concerned about these trends in early onset. And they basically commissioned some modeling studies to really try to understand if screening earlier would result in a significant decrease in colorectal cancer and mortality related to that. And the models really convincingly demonstrated that due to the rising incidence of colorectal cancer in these younger individuals, screening out average risk persons between the age of 45 and 75 would reduce mortality from colorectal cancer with an acceptable risk. That seemed to be clear from the modeling studies, and the benefit burden balance strongly favors changing the starting age from 50 to 45. So that was 2018 when they published this report, and it was in May 2021 when the United States USPSTF, the task force that actually really, when they come up with recommendations, is pretty much binding the insurance company coverage and Medicare coverage for these services. They also endorsed last year to start a colorectal cancer screening for average risk individuals down to 45 instead of 50. So that's where the medical societies have also endorsed that change, and that's where we live right now. And that's why Cindy's talking to us about this big challenge of really bringing all this newly eligible population from 45 to 50 to get screened, and also making a push for the 50 to 54, which is the group of individuals who's also very under-screened, even though for many years we've been recommending screening starting at 50, probably because there's this lag time in our message from when we start talking to our patients about screening until they actually have the first screening test. So very important that we actually also increase screening rates in the 50 to 54 because they are still a little bit low. So altogether, the recommendations from the USPSTF have been screening average risk asymptomatic adults ages 50 to 75 is of substantial benefit, but also through these modeling studies, the benefits can be extended to the starting age at 45. The benefits of early detection and intervention for colorectal cancer screening seem to decline after age 75, and from 76 to 85 really should be an individualized decision and taking really everything into account, particularly the overall health status of everyone. And the benefit after age 85, just because the morbidity or the potential problems with screening started to be disproportionately high, does not seem to warrant in these cases when we're age 85 and older to really have screening. So what are the options? We really have two sets of options, one that we call direct visualization options, and then the stool-based tests. And pretty soon you'll be hearing other ones, which are mostly blood-based, but we are not there yet. For this direct visualization, the more common one, the one that we've been more used is colonoscopy, but also the short-term test, sigmoidoscopy, along with a blood, with a stool test, and CT colonography every 5 years. Those are options that are endorsed. And then when we look at stool-based tests, then we have the fecal occult blood test that's really not being used much more right now because FIT test, which is an immunohistochemical test, base has been more broadly used. It actually performs better. And also the fecal multi-target DNA test, which is a mixed test that includes FIT tests and some DNA markers that are associated with sloughing off of cells that are malignant or premalignant in that colon. So those are our options. And this is the one we've been used the most. That's a colonoscopy, where basically patients are sedated, and then a tube is passed through the rectum and the entire colon. And the advantage of the test is not only you visualize the colon, but you can also remove those polyps, which, as we know, for the majority of cases, removing polyps is how we do prevent colorectal cancer to develop. The CT colonography is like a type of a CAT scan that's really focusing on the colon, and this seems to be extremely good for polyps that are starting to be of a certain size. Obviously, a positive finding will take us to a colonoscopy because that's how we can actually remove those polyps. But a negative finding would take us to a repeat in 5 years, if that's the test of choice. And this very graphic one of the stool-based test, which is really based on examining a sample of stool from the patients. And here we have this menu of tests that we are using right now. Colonoscopy, again, being like the final test if any of the other ones are positive. So we could actually call the other ones like pre-screening tests, but they can be very effective, particularly for average risk individuals, because if negative, there would be no need for colonoscopy. Yet if they are positive, then we will go with colonoscopy. Obviously, as we mentioned before, the advantage of colonoscopies is that as you are there, you can remove those polyps. But obviously, the drawbacks about a colonoscopy, it's a big production. It's a day off. It's sedation. It's having to come with someone else have the procedure done, is the preparation. So a lot of considerations that some patients are not so eager to do, and that's why the decision really should be based on really having that conversation with the providers and trying to figure out what suits best for everyone. CT colonography, the advantage really is that there's no need for sedation. They are still preparing the colon, and the colon gets inflated, but it does not require that sedation. And on the other hand, the stool-based test, that FIT test, and the Cologuard, the multi-target stool DNA test, the advantage is that you don't need to take a day off. It's a test that you can do it at home, and it's not invasive, so you don't expect any side effects from them. And as we said before, those tests, if they are positive, they take us to colonoscopy, but if negative, we can continue being tested that way, particularly if it's average risk individuals. When there is a family history or other factors, we tend to favor colonoscopy. But certainly for average risk, these are all legitimate options that we know they work. And again, I think you've heard that before, but the best test for screening is the one that gets done for sure. So colorectal cancer screening saves lives. That's been shown. That's clearly been demonstrated. No need to say more about it. And it looks like modeling is showing us that starting at 45 would also help us too. We'll see more on time, but at least modeling truly suggests very strongly that that's going to save lives too. There are different options for screening, and the best screening again is the test the one that gets done. 45 is the new 50, as Cindy said, and we'll stop repeating that. It's very important. That's a big message that over the last couple of years we've been trying to get out. And pay attention also to family history of cancer. We always have to talk about that and ask our family members for any history of colorectal cancer or even advanced polyps, because that means that we are at a higher risk. And actually recommendations are to start screening 40 and not at 45 or 10 years earlier than the earliest colorectal cancer in the family. And of course, if there are more cancers or there's anything that's suspicious for a syndrome, then what we need is to have an evaluation in cancer genetics to make sure we don't have one of those syndromes, particularly Lynch syndrome, that causes a very high risk of colorectal cancer. And I think that's all I wanted to share with you.
Thank you, Xavier. So we'll do one question now. And just to remind everybody in the audience, you can feel free to message me directly questions or just put them in the chat, and that should be fine. So Xavier, are there people you recommend a stool-based test for instead of a colonoscopy? Sure.
So in general, we try to recommend it for average risk individuals, meaning no family history, and obviously not to anyone who's had adenomatous or serrated polyps. That would not be a person who will want to do stool testing, because those individuals have already shown us that they have a higher risk of developing lesions, and therefore those would not be the prime candidates. But then average risk individuals who again may have issues about taking a day off, or actually they may consider that the risk of colonoscopy is something that scares them, or something like that. Or individuals who have a hard time finding someone who will go with them and spend the day with them, really to take them back home and all that. What we just want to make sure is that we do know we have that conversation. So actually we together with the patients can choose the right test. Again, the drama, and I think one of the biggest issues we had for many years is us as physicians, we've been prescribing colonoscopies like this without having those discussions. And then all of a sudden our patients won't show up for the colonoscopy because we did not go through all the issues and what it means to really going through a colonoscopy. So I think what this really calls for is having those conversations, finding the right test for every patient. So again, the test that is the one that's going to get done is what really matters, not just prescribing colonoscopies. Again, with the high risk individuals, we would look at things differently. But in general, for this big chunk of population that are average risk, certainly those are very legitimate tests that they've been shown to prevent mortality. That's been done. And so we don't have any issues about that. And again, it's just making sure that everyone who's eligible gets tested.
Excellent. There are more questions, but I'll save them for the end so that we make sure we get through everybody's talk. So next is Dr. Vikram Reddy. Again, he's Associate Professor of Surgery, and he'll speak about the role of the colorectal surgeon in colorectal cancer management.
Thank you, Mike. Thank you, Dr. Laura, for talking about screening. But for those unfortunate patients who, even despite screening, they find a cancer, the surgeon gets involved in those. As far as we know, the distribution of colorectal cancer varies depending on the location of the cancer. About 30% of these cancers tend to be on the right side. So we actually tend to have more on the left side, and about 20% tend to be in the rectum. Now, the outcomes for these cancers are different because it starts even in embryology. Like the cancers which are on the right side tend to be derived from the midgut, and they have different genetics compared to the ones that derive on the left side. Now, I know it talks about overall prognosis. Please ignore that because chemotherapy has gotten better, so this becomes kind of neutral at this point. Now, once someone gets diagnosed with colon cancer, surgery depends on the anatomy that we deal with. So people always ask me, one common question is, if I have a small colon cancer, how come you're taking out a foot of the colon? And it has to actually do with the blood supply to the colon. So if the cancer is here, when I take out the blood supply to the colon, unfortunately, I got to take out this big piece of colon. Now, this is an idealistic view of the colon anatomy. Now, in real life, inside the body, it sort of looks like this. These are the blood vessels. So if someone has a cancer here, because we're taking out the lymph nodes and the blood vessel here, I will be ending up taking out a bigger piece of colon, usually about a foot on average. Now, the surgeries have evolved over time. Initially, even when I was in training, patients used to have this big incision right around the belly button, where we used to put the hands in and do the surgery. At Yale, for the past 12 to 15 years, we've been pushing the envelope a little bit, and we've been doing it with little holes. And then usually we have to give an incision where we extract the specimen out because we can't chew up the specimen and pull it out through one of the small holes. So for laparoscopic surgery, what we used to do was that we would insufflate the belly with air, usually carbon dioxide, and then we use these little instruments to go and dissect out the blood vessels, dissect out the colon, and do the surgery that way. But over the past 2-3 years, mainly so that we can make minimally invasive surgery more accessible to everyone, we have started using the robot. People always ask me, is there a difference between the robot and the laparoscopic approach? People who are good at laparoscopic are able to do the robotic surgery, but the robotic surgery makes it a little bit easier to do the minimally invasive surgery. The second thing is it's much easier on the surgeon because they're sitting down. Here you can see the surgeon sitting at the console. Here's the robot, with the instruments here, and the surgeon manipulates the instruments and they do the surgery. The visualization is phenomenal. Like you can actually see very clearly, you can see every little baby blood vessel along with the major blood vessels. So the surgeries tend to be more precise, and it's much more easier to do the surgeries. First, let me talk about colon cancer, because colon cancer is different than rectal cancer. And even in colon cancer, we differentiate between right-sided colon cancers and left-sided colon cancer when it comes to surgery. Now, when any patient gets diagnosed with colon cancer, the first thing we make sure is that the colonoscopy has tattooed the lesion so that we know exactly where the cancer is. We usually do this blood work. We also do a CAT scan to make sure that we don't see lesions like this in the liver, and this is an indication of metastatic disease. If a patient doesn't have any metastatic disease, then we proceed for surgery. And the goal of surgery is to, first, we make sure that there's no tumor within the belly, anywhere outside of the colon. We make sure we remove the segment of the colon with good margins. And then we make sure that we do a wide lymphadenectomy, which is taking out all the lymph nodes that drain that segment of bowel so that we don't leave any possible cancer behind. So here is an example of right colon cancer. So pretty much anything that comes up here, here, or here is considered right colon cancer. Pretty much anything to this side. In reality, inside the body, it looks sort of like this. So imagine there's a cancer here. The way we would approach it is that, we can do this both open or laparoscopic. First, what we do is we divide the blood supply so that any of these cancer cells don't travel through the bloodstream somewhere to the heart, lung, liver, stuff like that. And then we start dividing the entire blood supply to the piece of colon we're taking out. Then we divide the small intestine and the colon. And then we free it up from the side walls. We also free it up from the liver because it's on the right side. We free it up from the kidney and vital structures underneath the colon. And then we do the connection in such a way where the small intestine is hooked up into the colon. For left-sided colon cancers, there's only pretty much two options. You can get the cancers way up here or cancers a little bit lower. And for that, depending on where the tumor is located, we take out a bigger piece of colon. Here in this example, we're going to look at a cancer up here. Similar to the right-sided colon cancers, we first identify the blood vessels. We divide it so that the cancer doesn't travel in the bloodstream. We divide off the bowel, free up the attachments. Now on the left side, from the left belly wall and also from the spleen and the stomach. And then what we do is we use the specialized stapler, which goes through the anus, up the rectum, and we kind of reattach the intestine sort of like this. So for most patients who have had rectal cancer surgery or left-sided colon cancer surgery, we do this kind of connection. Usually patients are in the hospital about 3 to 4 days. Some take a little bit longer, especially if you do this laparoscopically. There's some diet restrictions for about 2 weeks, and usually patients are able to return to normal activity in 6 weeks. And hopefully if they need chemotherapy or anything like that, they should be able to start it within a month after the surgery. And afterwards, we do a colonoscopy in a year, a CAT scan every year, and blood work every 3 months. Now, this is for colon cancer. Rectal cancer is kind of different. For rectal cancer, in addition to the CAT scan, the blood work, we also get an MRI. And the purpose of the MRI, and we used to do ultrasound before, but we have now switched over to MRI because it's better. The purpose of the MRI is to make sure that the cancer has not gone through the wall into the fat or into the lymph nodes. If it has gone into the fat or the lymph nodes, then we like to do chemotherapy and radiation. And I will leave it up to the oncologist to talk about the different regimens we have. And there's been some changes even recently. And they will talk about the regimens. And once they're done with the chemotherapy and radiation, then we come in for surgery. Again, the goal of the surgery, just like for colon cancer, is to make sure it hasn't spread anywhere. Completely remove the piece of bowel, which is involved with the cancer. Remove the lymph nodes. But for rectal cancer, it's different because it's much lower in the colon, because the cancer is somewhere here and here's the anus. What we want to do is reestablish continuity, meaning avoid a permanent bag when possible. But the goal, this should not be the primary goal, because in some patients, if you reestablish the connection and if they're not able to have good outcome, meaning they're either incontinent or going to the bathroom 20 times a day, that is actually worse. It's actually better to have a bag in those situations. The key for rectal surgery, more than colon surgery, is to know the anatomy. So these are the sphincter muscles, which control when we poop and make sure that we don't have accidents. As long as the tumor is above this area, meaning somewhere up here, and we have a 1 centimeter margin, which is a margin probably the size of your index finger, we can reattach the intestines. Now, usually I start with the least aggressive one. For some cancers, which are very early cancers, what we can even do is go through the anus. Here we are using the cautery, kind of cutting out the lesion, going all the way down to the muscles, and then sewing it up. But these are only for select patients, or even for advanced cancers and older patients who can't tolerate the operation. Then we started probably about 10, 12 years ago, a more fancier equipment where even for higher lesions, as long as they're pre-cancers or early cancers, this is laparoscopically, we go in through the anus, and then we use these instruments, and we're able to work on tumors even as far as 15 centimeters up. And it sort of looks like these instruments come out, and then we kind of dig it out. The problem with these is that if the tumor goes any deeper, we could potentially leave cancer cells behind. So we tend to do the more aggressive surgeries for the more deeper cancers. And the classic operation for rectal cancer, so in this case, it's in the upper rectum, the tumor. What we do is, if you look at it, this is the rectum and this is the sigmoid colon. But if you look at the line where we take out, we actually take out the entire sigmoid colon. And the main reason is it has to do with this blood supply. See on this picture, you can see it better. Here's the cancer. Here are the blood vessels. We have to take out all the lymph nodes here. And then because of that, once I take out this blood vessel, this piece of colon also comes out. And in the old days, before we really knew about rectal cancer surgery, what they used to do was, if this is the rectum, here's the fat around the rectum. If you notice, there's a lot of blood vessels. People used to dig right by the rectum and take out the cancer. When they did this, about 20 to 30% of the time, the cancer came back. Now we tend to be more aggressive. We go right next to the bone and in the front, almost close to the bladder, the vagina, or the prostate. And we actually take out all this fat and all the lymph nodes. And when we do this, just going from here to here, the incidence of the possibility of the cancer coming back has dropped to less than 7%. Now you throw in chemotherapy and radiation, it drops a lot more. So here's an example of how we do the surgery. Again, we first divide the blood vessel. Now this is for open surgery. We divide the bowel, and then we free up, this is the backbone called the sacrum, and we free up all the fat, which contains the lymph nodes and the rectum. Away from all of that, we identify and preserve all these nerves. Now here in the front, we're dividing the rectum of the prostate, or in this case, it's the vagina. And then we continue going lower. And the open surgery used to be much more difficult because you're operating in a deep opening, and patient's hand, the surgeon's hand used to go in there to kind of dig it out. And the surgery was a lot more bloody. And so slowly we have transitioned over to laparoscopic surgery, and we've been doing that here at Yale probably for the past 12 years. And usually once the surgery is done, we divide the bowel and reattach the intestines. Now with laparoscopic surgery, it's even better, or this is even robotic. What we do is we identify the blood vessel. This is the major blood vessel that comes off the heart. We identify it. We divide off the blood vessel, free up the colon. So here we're dividing the blood vessel, then free up the colon, mobilize the rest of the colon, free it up from every other tissue like the spleen and everything. And then here we can clearly identify all the nerves so we can preserve sexual function. If possible, if it's involved with cancer, we do take it. And then here we're freeing it away from the vagina, this situation. And here's an example of how it looks in real life. It's sped up like 5-fold, so we don't go this fast, but here we're freeing up here major blood vessels here. Here in this area, there's the tube which takes the urine from the kidney to the bladder. You saw the green light lighting up. That's a specialized dye we use to identify that. And then we have to get rid of all these lymph nodes, and there's a specific plane we need to be in to make sure we get all the lymph nodes. And here we're preserving the nerves which are involved with sexual function, which is right around here. And you see this huge whitish bundle which goes there, and we've preserved it. I'm not going to show the whole video. We continue to keep doing that and keep getting lower and lower. And now in this video, we're dissecting it off in the front. This is a male, so here's the prostate and everything. And if you notice, this instrument is about the size of my index finger. And if I had to do it with open surgery, where I have to have my whole hand in there, you can't see that much. So when we do it minimally invasive, we can actually do a much better surgery. And here we're dissecting off the prostate, preserving all the nerves, getting around the tumor. And once we get around the tumor and dissect it off the backbone, preserve all the nerves, we use a stapler to come across it. And then we usually remove the specimen through a protected area so no cancer implants itself in the belly wall. So in this one, there's a little video of how we do it. Here's the stapler coming in. We're going all the way down. So here's the bladder. Underneath it is the prostate. And we're just divided it. And then once we divide it, we bring it, we have the specialized stapler, we bring it in. Here's the camera holding up the bladder and the prostate, and we do this connection, and then we get these margins and make sure that there's no cancer in any of these margins. This shows you how it's being done. So there's the stapler coming from below. Here we're docking from above. The spike is getting deployed. So the spike and this thing, we call it the anvil, they kind of deploy, and once they're deployed, we kind of close it up. Oh, sorry. We got to repeat the video a little bit. So there's the spike. And most patients who have had rectal cancer have had surgery like this if they have avoided that. And then what we do is this comes together, and it's got these stables built into it, and it makes this connection. And you can see it coming together. So there's the rectum, or the lower portion, anus and rectum, and this is the colon from higher up. Now we have made the connection, and then usually we put some stitches to reinforce it because sometimes we don't trust the staplers all by itself. And there's different kinds of reservoirs we make. The whole purpose of the rectum is to store stool, and if you're removing a part of it, the capacity is decreased. So what we do is we kind of do this connection where, you have the rectum, and then you usually, there's another piece here, but because we don't have the piece, we kind of use this to make it a reservoir. Some people do this. The problem with this is that there's two areas where there could potentially be leaks. This, we do it only in select patients who are very young. It's called the Colonic J Pouch. After about a year, all three of them are equivalent. So, either one, any of these are good. And usually for low connections, especially for rectal cancer, we do give a temporary bag, and the bag sort of looks like this. And usually after you eat, the poop comes out this way. And if you actually go in down here, you can eventually make your way down to the rectum, but it's usually closed off. And then later on, we do a surgery to close it off. Now, for some patients where the rectal cancer tends to be much lower, like closer to the sphincter muscles, we do some unique procedures where we can avoid a permanent bag, but I'll go with the more traditional one where we take it out and patients end up with a permanent bag, because usually we take out the anus, and then so patients have a permanent bag. And what we do, most of the surgery is similar to what I just showed you, but in addition, what we do is we make this circular incision right around the anus. We kind of dig down into that area, we take out the muscles, and then we free up all the way down to the backbone. So here's the coccyx. We go all the way down to the coccyx, take off all this fat, and then the front, we take out all the tissue up to the prostate in this case. And in women, sometimes even the back wall of the vagina, we take it out, and then we sew it up. Usually patients are in the hospital 4 to 5 days. For the reoperative cases, patients are in the hospital even for 7 to 10 days. Most patients do have restrictions on diet for about 2 weeks, and they're kind of back to normal in about 6 weeks. For patients who have a bag, this ostomy teaching is very important. And we make sure that patients get the ostomy teaching both in the hospital and outside the hospital. Now, for some cancers, unfortunately, which extend into other organs, like in this one, it's extending into the prostate, we do this major surgery where we take out the bladder, the prostate, and the rectum. Or in this case, it's extending into the uterus. So we take out the uterus, and sometimes if it's extending into the bladder, we even take out the bladder. This one, I'm going to leave it for another more intensive talk. And people always ask me, what is the future? We used to do these with big incisions, measuring, probably, at least a foot in size, to now with these little holes. This device is not FDA approved, but it is a robot which we can make small incisions, one small incision, and we have these instruments that come out which bend. And we can do these surgeries through one incision. So potentially we can do it. So we have done this with animals where, we're able to go through the anus itself and do the entire surgery through the anus. I think we're a long way away from doing these in humans, but I think that's the future. Any questions?
Thank you, Dr. Reddy. So one question from the audience: do you routinely recommend aspirin or other measures after surgery?
So I do recommend aspirin to some patients. I make sure that they have no other contraindications for the aspirin, but not to everyone. Is this for blood thinners after surgery, or is this?
I think more in under the theme of reducing recurrence.
No, the aspirin by itself doesn't do anything for reducing the recurrence, but it does decrease polyps.
Excellent. So I will save the other questions for the end, and we'll keep moving along. Next is Dr. Kimberly Johang, Associate Professor of Therapeutic Radiology. She'll be talking about the role of the radiation oncologist in colorectal cancer. I think you're still muted.
I am muted. I'm not muted anymore.
There you go.
All right. And then screen share. All right, can everyone see my slides? We're good?
Yep. Very good.
Mike, we're good?
We're good. Yep, we can see him perfectly.
Can't hear you though.
Oh. We can hear you.
Okay, so Kim Jo Hung. I'm a radiation oncologist and talking to you about for a few minutes the role of radiation, which we typically use for colorectal cancer in the management of rectal cancer and not so much colon cancer. So that's where I'll be focusing my discussion. Are people hearing me? I feel like I don't have feedback here.
We can hear you.
Okay, good. All right. So, how does radiation treat cancer? I tried to make this talk very patient oriented. So, how does radiation treat cancer? It's a local treatment option. We're directing radiation to pinpoint your tumor. The radiation damages the DNA in your cancer cells, so we're trying to make them not be able to grow anymore with the damage from the radiation, to provide local control of your tumor. Radiation is delivered by something called a linear accelerator. So that's what's pictured here. So you have these side panels that basically are imaging panels for alignment. So we can either do X-rays or CT scans to make sure that you're perfectly aligned for treatment. And then the head of the machine, which is the arm, will move around you to deliver radiation, targeting your tumor from all different angles, basically. So the first part is the imaging, and then the second part is the treatment from the machine that's moving around you. So the process of treatment in order to have a radiation therapy course is we start with a consultation to determine if radiation will be helpful in your treatment plan, obviously, and to discuss the risks and benefits of treatment, logistics of treatment, potential side effects. This is followed by something what we call a CT simulation, which is a planning process. We position your body how it would be positioned for treatment, make marks to ensure that you're in the consistent position daily for treatment, and then obtain a CT scan and use those images to plan your precise radiation treatment, working closely with our physics team, who we call our dosimetrists. The process then undergoes quality assurance checks with our physicists prior to starting your treatment. And then this typically takes about 2 weeks. For rectal cancer patients, we typically position you prone. I like to call it a massage table, but it looks like which kind of looks like that. But basically, the point of this positioning is to have your bowel move forward away from the treatment field, such that we can avoid it for treatment. After the simulation process, we devise a treatment plan to target your rectal cancer as best as possible, as well as the lymph nodes in the pelvis, which may harbor microscopic disease. And so this is just an example of how we're able to devise a treatment plan that's targeting the pelvic nodes and the rectal cancer while avoiding the normal tissues as much as possible. So for rectal cancer, typically treatments are daily, Monday through Fridays. over the course of 5.5 weeks, typically with a chemotherapy pill that synergizes with the radiation, acts as a radiation sensitizer. For certain patients, we do deliver radiation in 5 doses without chemotherapy prior to surgery. And those 2 regimens probably equivalent in terms of local control outcomes. So it's decided on a case-by-case basis. So we usually employ radiation prior to surgery. And the goal is to reduce the likelihood of cancer growing back after your surgery. So if your tumor, and the other benefit is that if your tumor is lower in the rectum, radiation can improve the likelihood that your cancer can be removed while sparing the sphincter muscles to avoid the need for a permanent colostomy. So this is some of the data just to demonstrate why we use radiation in the care of rectal cancer patients. So this Dutch study is a classic study showing that the use of radiation prior to surgery significantly decreased the risk of local recurrence after surgery, so your tumor growing back after surgery. In the classic German rectal study, the use of radiation prior to surgery versus after surgery improved local control, and also the ability to spare the sphincter, meaning that you don't have to have a permanent colostomy. And treatment was also better tolerated in the pre-op setting versus the post-op setting. Sorry. All right, so what are the other reasons that we would consider radiation for rectal cancer care? So the other roles are if you have cancer that has spread and causing symptoms. So we do typically do short course radiation, 5 to 10 treatments to improve symptoms. If you're having pain, for example, from something that's spread and caused pain from metastatic disease. And then the other thing that I wanted to focus on was the role of treatment for what we call oligometastatic disease. So if your cancer has spread to a limited number of areas, we can use something called stereotactic radiation to try to ablate these areas of disease and provide local control. So there is data that approximately 20% of patients with rectal cancer present with metastatic disease upfront, liver metastatic disease. But despite the presence of metastatic disease, we have lots of data to show that studies have shown curative intent therapy for these patients is definitely feasible. And so that's where local therapy comes into play. And so shown here in this slide set is just an overall survival curve from one such study in which patients with a solitary liver metastases were treated with curative intent, including liver resection or ablation, and we achieve overall survival, long-term overall survival for many patients. So where do we use radiation in the setting of patients with metastatic disease? So in those who are not a candidate for resection of their liver mets, that's where we consider Sbrt. So Sbrt basically is using multiple conformal beams or arcs to deliver high doses of radiation so that we can tighten the dose with rapid dose fall off beyond the target volume, typically delivered in 1 to 5 treatments. The high radiation doses result in an ablative effect on the tumor through vascular injury to the tumor, in addition to DNA damage to the tumor, which we typically see with conventionally fractured radiation. And depicted here in the picture below is just an example of an Sbrt plan delivered with arcs that move around you, conforming the dose to your tumor so that we can target the dose and as strictly as possible. So this is just an example of a liver Sbrt plan. And so when we deliver Sbrt, obviously we need to be quite accurate with target delineation, precise immobilization. And so this is an example of what a patient would look like for an Sbrt plan. We build something called a vac lock, which is basically a cradle that holds you in position for treatment. You put up something that looks like a blood pressure cuff on your abdomen, which limits your breathing motion. So that's the abdominal compression. We obtain a video CAT scan, so we call it a 4D CAT scan, but it's basically just a video of how your tumor is moving as you breathe, so that we can tightly distribute the dose onto that area. And then we place markers to assist with treatment alignment. And we can often treat in something we call respiratory gating, which is treating only in certain phases of the respiratory cycle in order to focus our treatment more precisely. So we have multiple studies that have evaluated outcomes for Sbrt as treatment for unresectable liver metastases. These mostly looked at colorectal, breast, and lung cancers with patients having 5 or less metastases, good performance status, absent or stable extrahepatic disease, adequate liver volume to be spared. And in these studies, so this is one example, this is a multi-institutional study. Local control was over 90% at 2 years and 100% for tumors that were smaller. And toxicity was quite minimal, only a 1 grade 3 toxicity. So I think this is for non-surgical candidates, something that is quite tolerable. This is a Saber Comet study that I wanted to bring up when we're talking about oligometastatic disease, meaning minimal metastatic disease, that basically demonstrating the role of stereotactic radiation in that setting. And so in patients with less than 5 metastases, so if your disease is limited to less than 5 sites and your primary tumor is controlled, and this included multiple primary tumor types, mostly breast cancers, prostate cancers, colorectal cancers, and lung cancers, overall survival, which is a great prognosis, right, was improved with stereotactic radiation compared to just continuing on your standard palliative care chemotherapy, with a doubling of median overall survival from 41 months with the integration of Sbrt versus just continuing on your chemotherapy. So increasingly, we've been using Sbrt for patients with limited metastatic disease because of this study. So while resection, I would say, and I'm going to leave this to Dr. Billingsley to discuss, because I know this is what he's going to be talking about. I think resection is definitely preferred as the management of limited metastatic disease, but SBRT, stereotactic radiation and ablation techniques from interventional radiology are really promising alternative local therapy options when resection is not feasible, with local control that is quite good. Overall survival benefit seen in patients who have limited metastatic disease. So I would say in conclusion, radiation we use as an integral role in the management of rectal cancer patients for local control in the pelvis, but also as an option to address liver metastatic disease in non-surgical candidates. With that, I will hand it off, I think, to Dr. Billingsley.
Well, first I'll just field the question to you. There were several questions about how you select patients with multiple disease sites for a local treatment like radiation, but I think you ultimately answered that quite well. So there's another question about the number of times that you can use radiation to the same area of treatment. Can you talk a little bit about that? Can you radiate the same area twice?
Right. So we can reirradiate the pelvis. It's always just a risk-benefit balance, right? So for patients who have a recurrence in the pelvis, we do reirradiate. Sometimes we do it with smaller doses twice a day in order to increase the ability to tolerate treatment. And then we can reirradiate areas away from the site if there are limited metastatic sites that we're trying to treat. So I think those would be the two scenarios where we would reirradiate.
Excellent. So next we could certainly next will be Dr. Kevin Billingsley, Professor of Surgery and Chief Medical Officer of Smilow Cancer Hospital, and he's going to speak about the role of the surgical oncologist in the management of colorectal cancer.
Well, thank you very much. It is a pleasure to be with the audience this evening and with my co-panelists. I will be speaking about metastatic disease, predominantly colorectal cancer, liver metastases. Is it possible for me to screen share?
Oh yeah, Dr. Johan, can you stop sharing?
Thank you, folks.
Good now, Kevin?
Yeah, I think that is good.
I can see your slides.
Okay. All righty. So, I'm a hepatobiliary surgeon. So a lot of what I do is take care of patients who have colorectal cancer, which is spread to their livers. And the title of my talk is Progress in Multidisciplinary Treatment of Metastatic Colorectal Cancer, New Hope and Opportunities. And this is certainly a field where we as surgeons are very gratified to be able to offer patients new surgical approaches. But I emphasize the fact that this is a multidisciplinary endeavor, and a lot of the progress we have been able to make in surgery is closely tied to progress that has been made in the efficacy of systemic therapy, particularly chemotherapy and the integration of biologic agents. So, we know that colorectal cancer remains a major source of cancer-related illness in Americans and around the world. There are about 1.4 million new cases of colon cancer every year. And unfortunately, the liver is a common site for this disease to spread. In fact, it's the most common metastatic site. About 50% of patients with colon cancer will develop colorectal liver metastases at some point during their course. And in fact, 15 to 25% of folks who present with this disease have synchronous liver disease, or in other words, they have liver metastases at the time they're diagnosed. But the great news and the exciting news is that we have learned that long-term survival is possible if we're able to completely remove or resect the disease in the liver. Now, why do we want to do this? Well, liver disease is often the major life limiter in metastatic colorectal cancer because it can cause liver failure, it can cause biliary obstruction, and once folks get biliary obstruction, it's very difficult for Dr. Cecchini and company to give them effective systemic chemotherapy. So again, the exciting news is that with resection of colorectal liver metastases, patients are experiencing well over 50% 5-year survival. Now, the challenging thing is that not everyone is a surgical candidate for these operations. And roughly, we say about 20% of patients with these metastatic lesions are resectable at the time of their presentation. Now, many of them were able to move into the realm of resection with some treatment. So increasing numbers of patients become surgical candidates. And what has been gratifying for me over my career is that over the past 20 years, the median survival, 5 and 10-year survival for patients with surgically treated colorectal cancer liver metastases has steadily climbed from a 5-year survival of around 30% to well now over 45 in this series, but even now it's well over 50%. So very exciting progress. Now, when we talk about liver surgery, we can do major surgery on the liver for one simple reason. The liver is a remarkable organ. As a matter of fact, we can do quite extensive surgery like this where we remove over more than half of the liver. We remove the right liver and a little bit more, and the remaining liver is able to regenerate or regrow. And this happens remarkably quickly. Most of the regeneration occurs within about 35 days after surgery. So these are what we describe as standard liver operations. But in recent years, we have come to appreciate that the liver has a multitude of smaller anatomic segments in them. And we're able to do very carefully tailored operations where we remove these smaller segments to remove tumors that are multiple or on both sides of the liver. As I mentioned, we can't really talk about colorectal liver metastases surgery without staging it in the background of the progress in chemotherapy. And when I first started into this field, we really only had 1 or 2 drugs to treat the disease, and the median survival was relatively short. We now are up in this era where we have multiple regimens, either oxaliplatin-based or irinotecan-based. We have biologic agents, and often we combine all 3 of the active drugs to treat these tumors, particularly when we're trying to get them to downstage or shrink to get people to surgery. So we have a lot of strategies to try to get people to these liver operations if they're not surgical candidates at the time we first see them. One approach is to use the chemotherapy to shrink the tumor away from critical structures. One strategy is to use something called portal vein embolization, which is something that the interventional radiologists do to help grow or optimize the size of the liver remnant that we plan to leave after the operation if it appears too small. One approach is to break the liver operation into 2 segments where we allow part of the liver to grow between the operations. And then something that I do a lot of is very complicated parenchymal sparing resections, which means removing multiple small tumors with narrow margins. So all of these are tools in our armamentarium to use. This is an example of one of the things that I'm describing, where even a very large tumor like this is a patient's CT scan, and this is a metastatic tumor in the liver. With chemotherapy in advance of any surgery, the tumor was shrunk considerably, and we were able to do quite a straightforward operation to get this out. We also see situations where these tumors in the liver can be quite large, and they can be butting up against adjacent structures in the abdomen. And by shrinking them, again with chemotherapy, a safer and more effective operation is feasible. The other thing I talked about is doing the operation in 2 stages, 2 pieces. And this is 2 separate operations, but if we can do these operations safely, that is really a priority. So this is for patients with multiple tumors in the liver, on both sides of the liver. We start with an operation removing the tumors from one side of the liver, and then we do a procedure to grow this small area by blocking off the blood supply to the right side of the liver, and then we eventually take that right side out. So even very complicated multi-site disease on both sides of the liver can, in many cases, be safely and effectively treated. Another tool that we often use is something called microwave ablation. And this is a way that we can put a microwave antenna or probe into the liver. Often we do this laparoscopically through these smaller incisions to avoid a larger operation. And this can be used to treat tumors that are not safely resectable, or in patients who are otherwise not candidates for a major abdominal operation. One of the things that we're excited to be offering here at Yale New Haven and throughout our system is robotic liver resection. Now, not every individual is a candidate for this. It depends on the anatomy and the location of the tumors and size. But as Dr. Reddy described, robotic technology has definitely extended the reach of minimally invasive surgery through the use of 3D stereoscopic vision and a wristed functionality inside of the abdominal cavity, and it allows us to do very precise resections with suturing, and we can also it optimizes our ergonomics, and we can work with a trainee so they're learning as we go. So in the management of colorectal liver metastases, optimal care involves bringing all of these pieces together, including gastroenterology, my partners in colorectal surgery, including Dr. Reddy and colleagues, medical oncology involving the systemic therapy, pathology for accurate staging and sequencing, hepatobiliary surgery, which is what I do, imaging, radiation therapy, interventional radiology, and bringing those all together around our patient through tumor boards and through our care model is really our goal. And that's how we get the best care and best outcomes. So I am happy to take any questions either now or later. A very exciting time in this field.
Thank you, Dr. Billingsley. So when you are considering a resection of a liver metastasis and there's also a colon tumor, how do you prioritize what to do first, or can you do them at the same time?
Really a great question. And this is, again, points to the importance of multidisciplinary tumor boards, where I'm having discussions with the colorectal surgeons, the medical oncologists, the gastroenterologists, and it is very much patient dependent. There are times that we actually do prioritize removing the liver disease first, because it is often kind of the element that's going to impact the long-term survival most. It also requires some thoughtful sequencing with the chemotherapy. However, if the colon tumor is causing any symptomatology, pain, obstructive symptoms, we tend to deal with that first surgically.
Excellent, thank you. And so we'll move on to our final speaker of the evening, Dr. Thumar, who's an adjunct professor of medicine, and he practices at in Hartford at St. Francis Hospital, and he's going to speak about the role of the medical oncologist in colorectal cancer management.
All right, good evening. Thank you all for joining tonight. I'm going to share my presentation. All right. All right. So my goal is to give a brief overview of colon cancer treatment tonight. I would like to discuss the following topics. The first is, how do we define stage in colon cancer, and what is the prognosis with the individual stage of the colon cancer? I'll then talk about treatment for early stage and stage metastatic colon cancer. General overview of anti-cancer medicines, chemotherapy, biological therapy, immunotherapy. We'll briefly discuss that. I'll briefly talk about recent advances in colon cancer, and then we'll briefly talk about future and the research and clinical trials that we offer at Smilow Cancer Center. So I'm going to start with a real life case. This is a gentleman, JJ. He's 57. He's already 12 years late in getting colonoscopy. He is afraid of snakes, and somebody told him that colonoscopy looks like a snake, so he didn't want to go near colonoscopy. However, he started developing some fatigue and some symptoms. He saw his primary doctor. He was found to have iron deficiency, and the primary doctor offered him to do stool card testing, which came back positive. And then finally, he mustered courage to get a colonoscopy, which lo and behold showed a mass in his colon. There was a biopsy done. Biopsy confirmed that he has colon cancer. Luckily, he had a CAT scan of the chest, abdomen, pelvis for completion of staging, and there was no cancer spread to other organs. He saw a trained colorectal surgeon and had undergone surgery very successfully. And then he saw me after the surgery to discuss further options. So we started talking about the colon cancer stage, and I described him. So for colon cancer, the stage, the way we define the stage, if you look at the left-hand side diagram, the ring is the colon. Colon, as you know, is like a garden hose. The cancer typically starts from the inner lining of the colon. If the cancer is confined in the inner lining and doesn't go deeper, we call that as stage 1. And for most patients with stage 1 colon cancer, it is curable. All they need is usually a surgery. And of course, Dr. Reddy had mentioned about follow-up after the surgery. So these patients don't need chemotherapy. So that's stage 1. JJ did not have stage 1. He actually had stage 2 colon cancer. So stage 2 colon cancer, as you can see, the cancer is deeper, penetrating into the wall of the intestine. And surgery is, again, curable for most patients. However, about 10 to 15% of patients can still develop recurrence after undergoing a successful surgery. Even though cancer had not spread to the lymph nodes or other organs, there's still risk of cancer recurrence and cancer spreading to other organs. So some patients in this particular category will require chemotherapy. And Joe was very upset with this number 15%. He's a nuclear scientist, and 15% for him is a big number. And he would not accept that. And he asked about what else can be done to minimize the risk of this recurrence. So few patients with colon cancer with this stage 2, we consider them as a candidate for chemotherapy. We look at the tumor under microscope and we figure out how aggressive the tumor looks, if the tumor was invading the vessels. And there's a marker called microsatellite instability, MSI marker. If somebody has MSI positive colon cancer, that's a good sign. And those patients typically do not need chemotherapy. In JJ's case, he had no poor features. So there was no strong recommendation for us to offer him chemotherapy. And we briefly discussed the clinical trial. He remains very nervous and very confused. So I kind of tried to explain him with this diagram that I draw for him. So I told him, if I have 100 JJs like you, there are no real technology for me to tell you who are those 85% lucky JJs, and there are 15 of them unlucky JJs. The unlucky patients are patients whose cancer will return if I don't give them chemotherapy. And if I want to prevent a small number of patients getting the cancer, I have to treat all 100 patients. So in order for me to provide benefit to 3 patients, as you can see the extreme right picture, there are 3 patients who do not develop chemotherapy, do not develop recurrence. So he understood that a lot of patients will require chemotherapy in order for us to provide benefit to very few patients. And there are patients who will not even benefit from chemotherapy, and they will still have a recurrence. And then we talked about what other things can be done. So I discussed with him about what we call circulating tumor DNA test. This is the latest technology that we have now. It's a blood-based test to detect tumor molecules. It is very sensitive and very specific, and is very complementary, or in fact, it's superior to CAT scan in many situations. We are hoping that this technology, this blood test, will allow us identification of high-risk patient like JJ maybe, help in making a decision about who can get chemotherapy and who can avoid chemotherapy. This technology can also, we are hoping to help us monitor for recurrence after they've done with their treatment, along with CAT scan and other blood work and exam and colonoscopy. And we are also hoping this technology in future will help us monitor treatment for people who have advanced cancer. So I offered a clinical trial to JJ, which is being conducted at Smilow. Ironically, the name of the trial is Cobra trial, but JJ actually looked into the trial and he is considering it. So essentially for stage 1, there is no chemotherapy, just surgery. For stage 2, some patients may require chemotherapy. We are still trying to figure out who are the patients who gets the benefit from getting chemotherapy for stage 2 colon cancer patients. And we strongly encourage patients to participate in clinical trial, which we hope will help us answer this question. I'm going to talk about a second case. KB, he's 63. He's a gentleman who's otherwise very healthy, had colonoscopy when he was due at age of 50, but he misses colonoscopy, second colonoscopy, because of COVID-19. He presents with rectal bleeding, and he undergoes colonoscopy, which shows a mass in his colon, and he subsequently had a biopsy and a staging workup. Fortunately, again, the CAT scan did not show any spread of cancer to the other organs. He was seen by colorectal surgeon and underwent a surgery. He saw me after the surgery. Unfortunately, in his case, the cancer was actually not only invading the whole circumference of the intestine, but also had spread to the lymph nodes. So his stage is stage 3. So stage 3 is a cancer that has metastasized to the lymph node. His CAT scan showed no cancer in the liver, no cancer in the lung. So in this stage, it is still curable. However, there is a substantial risk of recurrence or metastasis in these patients. About 60 or 70% of these patients are cured by surgery alone. However, if I combine surgery with chemotherapy, as I said, the chemotherapy adds benefit to surgery, and in this particular stage 3 case, it improves the survival, and we can cure almost 80% of patients with this strategy. So certainly, surgery alone is not sufficient for people who are healthy, and we recommend them chemotherapy. Now, chemotherapy for stage 3, we have 2 different regimens that we currently use. One is called FOLFOX6, which is an intravenous chemotherapy. The other option is called K-Pox, which is a combination of a pill and IV chemotherapy. For a long time, we were recommending 6 months of chemotherapy to all our patients. In last 5 to 10 years, we have been asking this question: does everybody need 6 months of chemotherapy? And there was a trial done called IDEA study, and in that particular trial, we were able to conclude that if we use K-Pox regimen, the regimen with the pills and IV chemotherapy, we can conclude chemotherapy in 3 months. The 3 months of that regimen is equivalent to 6 months of that regimen, and therefore, a lot of our patients will choose 3 months of chemotherapy if they want to shorten the course of chemotherapy. However, there are certain patients that we will still choose a FOLFOX versus K-Pox, and that decision is usually based on discussion with a physician and a patient, and medical issues of the patient as well. So this particular patient chose 6 months of FOLFOX chemotherapy because he did not like taking pills and other risk profile or side effects profile that we discussed. He chose FOLFOX for 6 months. I'm going to go to another case of mine. This is DK. She's 72. She does not like to see doctors. She barely saw her primary doctor and never had colonoscopy. She started experiencing weight loss, abdominal pain, and generalized weakness. Finally went to emergency department and had a CAT scan, which showed multiple liver spots and multiple lung spots and a mass in her colon. She had a colonoscopy and a biopsy of the liver, and that confirmed that she has metastatic colon cancer originated from the colon traveling to lung and liver. So when she saw me, she had the cancer already metastasized to lung and liver, and I discussed treatment with her, and I recommended that she should take chemotherapy with a biological therapy, and I'm going to discuss that in a little bit detail in subsequent slides. We did discuss her case in multidisciplinary GI tumor board at Smilow. Dr. Billingsley and many other surgeons, we were able to review her scans with other doctors and team, and she was deemed not a surgical candidate because she has a lot of cancer in the liver as well as in the lung. And therefore, we chose her to start to give her chemotherapy as her first modality of treatment. So there are few patients who can be cured and can have long-term control of their disease with surgery and chemotherapy for stage 4 colon cancer, but she was clearly not that particular type of patient. So she has stage 4 colon cancer, and she was really upset with her diagnosis, reasonably so. She understood that her cancer is likely incurable. However, I told her that there's certainly a silver lining, if there is a silver lining. There are many recent advances in colon cancer treatment. We have many tools to treat patients with stage 4 colon cancer. And I mentioned to her that life expectancy, even with advanced stage 4 colon cancer, has improved significantly. The SEER database is what we use as our marker to tell patients how well people are doing in last many years. So if you from 1976 to 2014, the risk of death from colorectal cancer has substantially declined, almost 50%. And on an average, stage 4 colon cancer patients are living more than 2 years and 3 years nowadays with chemotherapy and focusing on quality of life as well. So stage 4 colon cancer patient, our treatment, when we talk about treatment, we talk about few things first. First is, how does the patient look? What we really pay attention to is what we call ECOG performance status and age. How a patient is doing in general in terms of activity of daily living, how many hours patient is walking, exercising, taking care of the house, doing chores, driving. All those things matter the most. So patients, more active the patient is, there's a good chance that the patient will be able to handle chemotherapy, and there is very substantial chance that that patient can live longer on chemotherapy. Other health issues, certainly very important: smoking, obesity, other health issues such as diabetes, high blood pressure, kidney problems. Physical activity and exercise is very important. We counsel all our patients to stay physically active and choose a lifestyle. Even they have stage 4 cancer diagnosis, choosing an activity and also choosing a healthy diet and healthy lifestyle will still have a substantial impact on their life and their tolerance to chemotherapy. So that will be continuous counseling to the patients. Now, how does the cancer look? That's another way to figure out what kind of chemotherapy we're going to choose. So there are a few things that we will look at when somebody is diagnosed with stage 4 colon cancer. We look at the pathology, and this information called microsatellite instability, or MSI, high or low, will help us decide what type of first line treatment we will choose. The second most important test that we would check is called RAS gene mutation status. There are genes called KRAS and BRAF. These genes, if they are mutated or not mutated, will help us decide our first step in terms of deciding chemotherapy and biological therapy. And the third test that we would use is called HER2/neu testing. And there are more and more molecular mutation testing that we are utilizing nowadays, and we are hoping that we'll be tailoring our chemotherapy and biological therapy to individual patients. but we have done a substantial work in science, and science has advanced tremendously that we are even at this point, we are able to decide what kind of treatment is best for a particular patient. So treatment for stage 4, what is our goal? She asked me, what is going to be my life and why are you giving me chemotherapy? If my cancer is going to kill me eventually, why should I go through chemotherapy? And what we counsel patient is, the purpose of chemotherapy here is, first of all, palliation of disease-related symptoms. This particular patient actually had bloating, had minor rectal bleeding, abdominal pain, and we hope that chemotherapy will provide relief of a lot of these symptoms. So that's our first purpose of giving chemotherapy, called palliative chemotherapy. Second is to prolong life, which is always a first thing that patient wants to know. But as a physician, my goal is to provide quality with life. And the third thing is to decrease the tumor burden for successful surgery, like Dr. Billingsley mentioned earlier. Patients who can potentially go for surgery, giving them chemotherapy up front will reduce the burden of the cancer and will have successful surgery. And we hope that some of these patients can be cured. So for treatment for stage 4 colon cancer, the first line treatment, if somebody has MSI high colon cancer, we now have immunotherapy. Immunotherapy essentially is a cancer vaccine, you want to call them. It allows your own immune system to fight cancer. This antibody called pembrolizumab or Keytruda will enhance your immune system and allow your immune system to attack the cancer. This is a very effective treatment for people who have MSI high colon cancer. There are some patients who will have cancer-free or remission period for a long time. In some cases, we have seen patients going many years on this immunotherapy treatment. Immunotherapy is very tolerable. It has side effects, but majority of patients on this particular treatment are side effects free and enjoy their quality of life. If you have MSI low colon cancer, usually the chemotherapy is the first option for treatment. We usually combine chemotherapy with biological therapy. Biological therapy are antibodies like bevacizumab and panitumumab. The standard treatment, there are two major combinations of chemotherapy. One is called FOLFOX. The other one is called FOLFIRI. They're both chemotherapy cocktail, a combination of two chemotherapy in each schedule. So this is typically, we decide this regimen based on patient's mutation status, MSI status, and how healthy they are. And an oncologist and a patient will have a long discussion before we come up with a treatment plan for them. In some selected patients, we use a regimen called FOLFIRINOX, which is a very aggressive regimen, particularly young and healthy patients, and particularly patients who are trying to get to the liver resection and try to get to almost near curative type of surgery. So that regimen is also being more and more utilized for young and healthy patients. As I mentioned earlier, the treatment has advanced tremendously in the last 20 years. Our main chemotherapy for years was 5-fluorouracil, and oxaliplatin chemotherapy came later, and then came irinotecan. So these are the main 3 chemotherapy molecules. However, in last 10 years, we have now at least 10 or 12 different treatment options for colon cancer. One is, as we mentioned, bevacizumab, which is a biological therapy. It is an antibody that actually allows the chemotherapy to be more effective. Bevacizumab will prevent the tumor developing vessels or artery and vein, and it will literally starve the tumor, and chemotherapy will enhance the effect of that. Cetuximab and panitumumab are, again, another antibody, a biological therapy. They're anti-EGFR therapy, enhances the chemotherapy effect, so we combine them with chemotherapy for treatment. We have now a third-line treatment, a medication called Stivarga. It's an oral pill chemotherapy. There's another medication that got approval about 4 or 5 years ago called Lonsurf, or TAS-102. We mentioned pembrolizumab as an immunotherapy for people who have MSI high colon cancer. There's another immunotherapy combination, ipilimumab and nivolumab, which we use for MSI high colon cancer. There are a small percentage of patients who have HER2 positive colon cancer. HER2 is a type of a receptor which amplifies in some colon cancer cells. And we use this combination of treatment called trastuzumab and pertuzumab, as well as another medication called trastuzumab and deruxtecan, another medication for treatment of HER2 positive colon cancer. There are some of about 5% of colon cancer have BRAF mutation, and we have this approval of medication called encorafenib, which is a chemotherapy pill, and we combine them with an antibody called cetuximab that also becomes our tool to treat BRAF positive colon cancer. So as you can see, there are many treatment options nowadays, and therefore our patients are doing much better than patients did 20 years ago. And in quick follow-up of all the patients that I have discussed so far, quality of life becomes a real thing. We want patients to remain active and healthy and also enjoy their life while they're on chemotherapy, which is counterintuitive, but yes, chemotherapy can be given to patients. Patient can still continue their lifestyle. We provide treatment holidays, liver-directed therapy, which will allow patients to stop chemotherapy for a brief period of time, lifestyle changes, and we talk about maintenance treatment, a lower dose of chemotherapy that we give for patients for a longer period of time, which will allow them to continue their life with lower toxicity. So there are various tools that we use for patients to enjoy their life. JJ, the first patient, actually finally enrolled in clinical trial at Smilow, and he remains cancer-free at 6 months. KB, stage 3 colon cancer, he just finished his chemotherapy very recently. He did develop mild neuropathy. He did have some fatigue. He was not able to work, so he took some break from his work. Very recent CAT scan shows no evidence of cancer, so he's about 12 months out from his diagnosis, and he's doing well. DT remains DT. She's enjoying her life. Her pain completely resolved after chemotherapy. She gained healthy weight. She's about 3.5 years out now from original diagnosis. She goes to Florida all the time. She hates Connecticut, except she likes Mohegan Suns. And she started liking doctors recently, so that's a good thing. She's on her second line of chemotherapy since last 8 months, and she loves chemotherapy breaks. In terms of future, we at Smilow offer many clinical trials. Without clinical trials, without science, we will not be able to advance our treatment for our patients. And we are so thankful to our patients who volunteer and participate in many of these clinical trials, which can lead to development of new drugs, which can help to millions of patients. We are hoping KRAS inhibitor, which is one of kind of drug which will be approved for colon cancer. Immunotherapy is one of the treatment that we are all excited about in many other cancers. It has not been successful in routine kind of colon cancer, which are MSI low. And we are trying to do a lot of clinical trials to see how we can harness the immune system and make the immunotherapy effective for all the colon cancer patients. Thank you so much, and I will happy to take any questions.
Thank you, Dr. Thumar. We're at time, and I think we did a good job of answering the questions in the chat. So I want to be respectful to everybody's time, and I want to thank our faculty members for speaking today, as well as Cindy from the Colon Cancer Foundation for joining us today. And most of all, I want to thank the patients and attendees from today for your time this evening. This will be posted online, and we're happy to answer any more questions by direct messages later. Thank you so much, everybody.